Welcome to Kidney Corner. It's an educational endeavor of the National Kidney Foundation of Indiana. I am Mahendra Govani, consultant nephrologist affiliated with St. Vincent Hospital. As you know, February is the Love Month and Heart Month. Therefore, we have chosen a topic, Love Your Heart and Kidneys. To discuss the subject, we have several guests. Our first guest is Dr. John Lucia, consultant nephrologist affiliated with St. Vincent Hospital. And he is going to discuss one of the commonest applications of the human being, and that is hypertension, which affects both organs, heart and kidneys. Welcome, Dr. Lucia. Please tell us about this common problem.
Hi. High blood pressure, commonly called hypertension as well, is a very common medical problem. It affects up to 25% of the American adults, and that varies country to country depending on where you are. The definition of high blood pressure means blood pressure greater than or equal to 140/90 when measured by a standard method. A normal blood pressure would be 120/80 or less. In between there is considered pre-hypertension. The prevalence or how common blood pressure elevation is increases with age, and it is associated with many other medical conditions such as diabetes, tobacco use, and obesity. It is a very important problem to have under control because it does affect so many other conditions such as the health of your heart as well as the health of your kidneys. It can lead to premature death and disease. The majority of patients with high blood pressure have what's called essential hypertension, meaning we don't know a specific cause of the elevation of their blood pressure. The people who have pre-hypertension tend to develop true hypertension over a course of 4 years. So 2/3 will progress to the definition or diagnosis of hypertension. The diagnosis and what defines hypertension is when 2 or more blood pressures in a seated position run over the 140/90 value. Sometimes, if it's difficult to tell exactly what the blood pressure is doing because it can be high sometimes and low others, we use what's called ambulatory monitoring of your blood pressure. In that case, that is a machine that checks your blood pressure every so many minutes throughout a 24-hour period. You wear it, it's in your pocket while the cuff is on your arm. This is used to exclude something called white coat hypertension, which occurs in people who have an anxiety with going to a doctor or they're outside their normal environment and their blood pressure is elevated for that reason. Reducing blood pressure is very important because it helps protect you from many problems, including heart disease such as congestive heart failure, stroke, and kidney disease. And this is regardless of how old you are, who you are, and how severe your hypertension is. Any reduction in your high blood pressure will be a benefit. It is easy to control high blood pressure for most people, and now most of the medications are actually very effective and available as generics and quite inexpensive. To evaluate high blood pressure, the first thing we need to do is evaluate what your blood pressure is and what other problems you may have where the blood pressure is affecting your health. And these include other factors including cardiovascular risks or other medical problems that may be developing, such as kidney disease or heart problems. The comprehensive evaluation includes taking a thorough history of what medications you may be using. Even if they're over-the-counter or herbal medications, they can still affect your blood pressure. Commonly encountered substances such as caffeine or even Some arthritis medicines, such as ibuprofen, can increase your blood pressure. And then a detailed physical examination by the doctor can help sort things out, as well as some laboratory studies to see if there's any evidence in blood tests or in urine tests that you have kidney problems or high cholesterol or blood pressure or blood sugar problems such as diabetes. And then an evaluation of your heart health as well. Controlling your blood pressure and what the goal is set out by what is called the Joint National Committee, and they put out guidelines. They're on their eighth version currently, and these came out recently. They define the goal of getting your blood pressure under 140 over 90 for people less than 60 years of age, and less than 130 over 80 for those with diabetes or chronic kidney disease or other medical problems. People over 60, the goal was set there at under 150 over 90, but this has had some controversy because of a recent study that came out indicated maybe they need to be a little more aggressive in lowering that for certain people. And then, of course, you can, in addition to medications, you can do lifestyle modifications such as quitting smoking, changing your over-the-counter medications, weight loss, and alcohol intake.
I think the medications-wise, what medications would be your preference?
Well, the most common medications to use first line would be a diuretic, such as hydrochlorothiazide or indapamide. Those are common, but there are many medications you can use first line. It really depends on the person, what else they have going on in terms of other medical problems, or how they tolerate them.
Sure.
And since there are such a wide variety, there are many choices that are good.
Okay, very good. So, now, diabetic patients, do they need some special medications would you use instead of the, say, diuretic to start with?
Well, diabetes is the leading cause of kidney failure leading to dialysis in the United States, hypertension being second. And so there are studies that show that certain medications such as ACE inhibitors or angiotensin receptor blockers have a special place and role to play in diminishing the risk of kidney failure. And those are usually in the first line of medicines we use to control your blood pressure in that case.
And women of childbearing age, would you avoid certain medications?
Well, some of those same medicines, the ACE inhibitors and the angiotensin receptor blockers, can cause problems with a baby developing in the womb, and in that case you might avoid them in women who are actively trying to get pregnant or have the possibility of that.
Thank you, Dr. Lucia, for educating us about this problem of epidemic proportion.
Thanks for
now
having
we'll
me.
take a short break. Thank you.
You know, when Margaret and I decided to sell the old estate here, we had only one choice in signage. Logan Street signs and banners. Conveniently not located on Logan Street anymore, but rather located on 10th Street on the south side of Noblesville. Well, we sold the old beauty, and we were able to buy this wonderful estate. And we had so much money left over, I was able to buy this beautiful 1968 Eldorado Cadillac for Margaret. Only 472,000 miles. Margaret loves it because it's got those big seats and that heavy-duty suspension to support her svelte frame. Next time you're looking for signs or banners, call old Jim at Logan Street Signs and Banners, 773-7200. Conveniently not located on Logan Street anymore.
Welcome back. In the first segment, we talked about hypertension. In the second segment, we want to talk about the interactions between heart disease and kidney disease. Heart and kidneys interact in health and in disease, and they sympathize with each other and they share each other's sorrows. To discuss these interactions, we call cardiorenal syndrome. Our next guest is Dr. Douglas Pitts, Co-Medical Director of Transplant Program, Heart Transplant Program at St. Vincent Hospital. Welcome, Dr. Pitts. Please tell us about this important issue.
Well, thank you, Dr. Govani. I'm happy to be here. We're going to talk about cardiorenal syndrome, and this is a syndrome that's really become prominent in the medical literature, even to the point where there may be a new organization forming to talk further about this. As you all know, we as humans, the human body is an incredible, integrated, mysterious sometimes creation, but the heart and kidneys have a very unique and I would say intimate relationship. And that's where we started talking about cardiorenal syndrome. And this is an umbrella term that's used in the medical field that defines disorders of the heart and kidneys, whereby acute or chronic dysfunction in one organ may induce acute or chronic dysfunction in the other. And so it's important that to prevent these syndromes, to keep both your heart and kidneys healthy, and the diagnosis of the diseases that frequently impact these organs are common disease processes such as hypertension that Dr. Lucia just talked about, as well as diabetes. There are 5 types of cardiorenal syndrome that we're going to touch on. The first one is certainly close to what I do frequently, and type 1 is acute worsening of cardiac function leading to decreased kidney function. And we see this frequently in the intensive care unit after someone's had a myocardial infarction. And the heart's job is to pump blood. And if the heart is injured or damaged through a heart attack, then that results in reduced output to the kidneys, and then the kidneys will quickly start to fail. There's also conditions such as acute myocarditis. It's an inflammatory process of the heart, which can reduce heart function on a very quick situation or process, resulting in decreased cardiac output. And this is frequently what I deal with as an advanced heart care physician. We see patients come in with what we call cardiogenic shock. And in those situations, we will see acute decline in kidney function. So when we treat these patients, we are frequently hoping to continue to keep the kidneys perfused so that Dr. Lucia is not called in consultation, usually on a Saturday night, to help us out. There's a second type that we call chronic cardiorenal syndrome, and this is where there's been some sort of insult to the heart and you're able to stabilize that patient, but over time the heart starts to fail. And because, again, of reduced cardiac output, pushing blood to the kidneys, we'll start to see a gradual, slow decline in kidney function. And in the work that I do as a kidney transplant physician, we're constantly trying to determine, is the kidney function dysfunction that's present due to the heart, or is it due to some underlying kidney disease as well? Now, to flip the coin, let's talk about acute renal cardiac syndrome, and that's type 3. And this is where acute worsening of kidney function can cause cardiac dysfunction. And acute renal dysfunction may be as simple as urinary outflow obstruction. It could be due to an acute insult to the kidneys. Whatever insults the kidneys suddenly or quickly can subsequently result in cardiac dysfunction. And the most emergent situation that we'll sometimes see is the potassium can elevate, which can cause acute sudden decline in cardiac function. And then also the other problem that we're faced with is the fact that the kidneys are not getting rid of fluid, resulting in volume expansion, fluid overload. There is subsequent heart dysfunction in that regard. Type 4 is where we talk about a chronic kidney condition, and over time, people that have developed end-stage renal disease can then start to develop chronic heart problems as well. Patients like this are frequently diabetic. They may be hypertensive. They may have obesity issues, but this chronic condition can result in persistent hypertension, high blood pressure, which can impact the heart negatively. Also, the inability to keep volume off or fluid off can result in chronic heart dysfunction as well. And then the last type is type 5. These are systemic conditions causing simultaneous dysfunction of the heart and kidney, and the number one cause, I would say, is diabetes. So that's cardiorenal syndrome in a nutshell. If we just look at cardiovascular disease and kidney disease, I think it's important for people to understand, particularly those of you who are watching that may have chronic kidney disease, that heart disease is very common in that population of patients. And it's very important that if you do have chronic kidney disease, that you're aware of that, that your heart is being evaluated, being assessed, because unfortunately, patients that have end-stage renal disease, 45% of deaths are due to cardiovascular disease. And so a full assessment of the heart in patients with chronic kidney disease is very important. And you know, in those patients that have subsequently developed end-stage renal disease, who've been on hemodialysis and subsequently are able to have a kidney transplant, I think it's important to point out as well that patients after heart transplant can still have this risk of heart disease. It's the most common death in the kidney transplant population. There was a large study that was done over a 10-year period that showed that 30% of those who died had functioning kidneys, but they died as a result of cardiovascular disease. And even in the immediate post-transplant state, there's a very high incidence. With 30 days of transplant, there was those who died, almost 50% of them died of cardiovascular causes, particularly acute MI. So I know Dr. Govani has frequently asked me to see his pre-kidney transplant patients to assess their hearts to see what the health is of their heart moving forward.
Would you agree that despite that, all the transplant-related cardiovascular problems, still the transplant is better than end-stage renal disease and on dialysis, because cardiovascular disease is probably less common in transplant? Is that fair?
That's not only fair, it's right on. I'm a strong advocate for renal transplantation in patients who have chronic kidney disease because I'm convinced from the data, from the studies, that it does reduce cardiovascular events. It doesn't take it away, but there is a significant reduction, and the lifestyle is much better.
Thank you, Dr. Pitts, for elucidating all the details about this important issue. We'll take another break. Thank you.
Thank you.
You know, when Margaret and I decided to sell the old estate here, we had only one choice in signage: Logan Street signs and banners. Conveniently not located on Logan Street anymore, but rather located on 10th Street on the south side of Noblesville. Well, we sold the old beauty, and we were able to buy this wonderful estate. And we had so much money left over, I was able to buy this beautiful 1968 Eldorado Cadillac for Margaret. Only 472,000 miles. Margaret loves it because it's got those big seats and that heavy-duty suspension to support her svelte frame. Next time you're looking for signs or banners, call old Jim at Logan Street Signs and Banners, 773-7200. Conveniently not located on Logan Street anymore.
Welcome back. In this segment, we plan to discuss prevention and policies for the prevention of cardiovascular diseases. To discuss that matter, I have Mr. Meixner with me. He is the Regional Vice President of Advocacy of American Heart Association and American Stroke Association. Welcome.
Thank you, Doctor, and thank you for having me.
So can you please describe how would you do the primary prevention? What is primary prevention? What is secondary prevention? And what are the policies of this American Heart Association and American Stroke Association?
Absolutely. So when we talk about primary prevention, we're really talking about reducing the risk factors that give rise to cardiovascular disease or stroke, as well as many other dire medical conditions, cancers, diabetes, etc. So we're talking about obesity prevention, improving diets, increasing physical activity. We're talking about tobacco prevention, getting folks to quit or not to start in the first place. So that's really what we're talking about with regard to primary prevention. In terms of public policies, what we want to do is make it easier for folks to live healthier lifestyles. So with regard to, again, obesity, for instance, we work with town, city governments, county governments, state governments, federal governments to try to increase what we call complete streets, so more sidewalks, more bike paths, more built infrastructure that will allow both kids going to and from school, right on up to seniors, to get outside and be a little bit more physically active. We're also working with members of the state legislature in Indiana right now to try to promote what we call a healthy food access initiative, which would help bring more fresh fruits and vegetables into corner stores, grocery stores, gas stations that might not offer that right now, because we know that both in urban centers as well as in rural areas of the state, many folks just don't have access to that healthy food that so many of us otherwise take for granted. So those are some things we're doing with regard to obesity prevention. With regard to tobacco prevention, our main initiative right now is trying to raise the state's tobacco tax. This is something that Indiana hasn't done in almost a decade, and if we look at our surrounding states, I can go to Chicago and a pack of cigarettes there might cost $14 or $15 because of all the state, county, and local taxes they've got. Just over the border in, let's say, Gary or Munster, that same pack of cigarettes is going to cost about $6. That's a significant difference, and we can use taxes as a disincentive to help folks quit, and we know from research taxes are incredibly effective at keeping young people and pregnant women from starting or helping them to quit. So right now there's a initiative at the State House where we're looking to raise the state's tobacco tax by $1 from 98 cents to $1.98, which we think will make a significant difference in terms of helping folks prevent tobacco use. And by the way, we'll also fund road construction for the state, which would be a very good thing. So those are some initiatives we've got going with regard to primary prevention.
Yeah. Cigarette smoking, we have come a long way. I mean, we to say about 30% of the population was smoking in 70s and 80s and 90s, and now it's about 13%. Do you think we have reached that bottom, or do we still have a way to go?
I think we've got a way to go. I think nationally things are trending in the right direction, but we're not yet there. We know that tobacco use is still one of the largest risk factors for cardiovascular disease, for stroke, for cancer, for diabetes, for so many conditions. And here in Indiana, we've got a way to go as well. Again, our comparative tobacco tax burden to our bordering states, we're lower than just about all of them. If we look at smoke-free, many of our bordering states have a little more stringent smoke-free laws, not allowing smoking in, say, bars or casinos, whereas we've not yet done that here in Indiana. So I think we've got room to increase the degree to which we're helping folks get off of tobacco.
Very good. And about the obesity part, of course, we are in a Hoosier state and obesity is very common. So apart from obviously educating them and the policy, is there anything else we can do about that?
Well, there's lots we can do. I mean, starting with each and every one of us. I was talking to a nurse practitioner recently who works with folks in her community on obesity issues, and one of the most important things that she says she brings to her patients is telling them to put a pair of shoes in their car. So they're driving home from work. If they see a nice path, a nice sidewalk, get out and walk for a little bit. Take every opportunity to take the stairs, to order the salad, whatever it might be. But we know that personal choice is only going to get us so far. We've got to make those personal choices easier, which is why we're looking to increase healthier vending options for folks that might be relying on vending machines. So there's a lot that we can do both individually and as a society here in Indiana to decrease obesity and really increase our cardiovascular health.
Thank you, Mr. Meixner. It's certainly, I think after this, we will be able to look after ourselves a little bit better.
Well,
Thank you. I appreciate that.
Thank you very much, Doctor.
Now, in the next few minutes, I will go over the activities of March, which is a kidney month. And there, we have a lot of activities coming. And many of the kidney walks, and all over Indiana, we do the kidney walks. That obviously helps the obesity prevention, as well as it raises the fund for the other actions of the National Kidney Foundation. And most of that money is used for the prevention purpose. We want you to start a team. Registration is completely free. There are many fundraising ideas on the internet, and you can go on the website and look for that. And funds raised and support local Hoosiers in need. And we do that all the time with this different money we raise. Now, March is a kidney month event. And 10th March is a World Kidney Day. And various activities are going to happen in March. And there is a special clinic going to be set up for the diagnosis of hypertension and kidney disease and diabetes. So Thursday, March 17th, there is a St. Patrick's Day parade, and there is a kidney group will walk there. And so please join us there. And in Fort Wayne also, they are doing a special event that day. So please visit all the different sites and take part. We encourage you to take part. And another important thing coming is the transplant games, Donate Life Transplant Games of America, and they are going to be in Cleveland, Ohio between 10th June and 15th June this year. And for more information, please contact our website. There you will find more details. In this particular things, the donors and recipients and their families, but mostly donors and recipients take part, and the families are encouraged to come and visit. Now, please visit our website for further information. We are www.kidneyindiana.org, and we have our Twitter and Facebook page. So, anytime. And thank you very much. And here is the end of the segment. So, thank you. Okay.
Thank you.
All right.